So welcome everybody to this Deafblind Information Australia webinar on cerebral cortical vision impairment. We're really pleased to have with us tonight Natalia Kelly, who is an orthoptist that works with Vision Matters, the Cortical Vision Impairment Community Australia, and with La Trobe University. She wears many hats. I'd like to acknowledge the traditional owners of the various lands that we're meeting across this evening across Australia and pay respect to their elders past and present. I'm here in Melbourne, or Naarm, on the land of the Wurundjeri and Woiwurrung people of the Eastern Kulin Nation. And it's very cold here at the moment, and it's the season of wearing, wombat season. For any of you here in Melbourne at the moment, keep an eye out for wombats, or just on Eastern Kulin Nation generally. So we do have captions for this webinar. If you want to access the captions, click on the CC button below. We're also happy for people to type in their questions as you go. If Natalia says something that you want more clarification on or piques your interest, please type in the Q&A box. We won't be using the chat function this evening, so please use the Q&A, and at the end of the session, we'll go through all of the questions. If you want to ask a question in Auslan, please type in the Q&A Auslan question, and we will allow you to share your video to ask that question in Auslan. And there are Auslan interpreters throughout the whole webinar. So it's my great pleasure to now hand over to you, Natalia, for this webinar on cerebral cortical vision impairment.
Thanks, Meredith. Hello, everyone. Thank you to Deafblind Information Australia for inviting me to present on cerebral/cortical vision impairment, or CVI, the role of the orthoptist in CVI care. Thank you also to the audience for being here tonight and expressing your interest in CVI. I thought I will start tonight's presentation to briefly discuss what an orthoptist is, to help give context as to how we fit into CVI and the CVI care pathway. I will also provide you with a fundamental understanding of vision and CVI, and then go on to talk about the orthoptist's role in CVI care, which involves functional vision assessment and intervention. I will leave you with some useful resources to help you locate information related to CVI. So the images I have on the screen are logos from Vision Matters, CVI Community Australia, La Trobe University, and PVI Alliance Australia. I'm Natalia. I'm an orthoptist who has been working in the low vision and vision rehabilitation sector for the last 20 years. During this time, I spent 15 years working in the non-for-profit sector, and more recently I started my own private practice based in Melbourne, which specialises in complex vision impairment. We also look at innovative evidence-based solutions to improve quality of life across all ages. Additionally, I work as an academic at La Trobe University in the discipline of orthoptics. I am the co-founder of CVI Community Australia, where we aim to bring people with CVI, their families and professionals together. I'm also a founding member of the Paediatric Vision Impairment Alliance, which is an advocacy alliance to help promote the needs of children with vision impairment. To start, I'd like to highlight a few points to remember during this presentation. The first is vision is a learnt sense. It is not innate, but develops through experience. By creating familiarity with various objects and concepts, we can facilitate improvement in recognition and visual processing. Visual acuity or detailed vision alone does not provide sufficient information about how someone uses their vision for everyday life. It is also not enough of an indicator to provide insight into how a child uses vision for development. Finally, when considering CVI, you need to remember that visual responses are variable and dependent on endogenous, so internal, and exogenous, external factors. If a person is tired or unwell, or the lighting conditions are not right, then vision will be affected. The image on this slide shows a man looking at a child's eye. There is a script on the image that says orthoptists are allied health professionals who work in eye care. The next two slides are a brief introduction to what an orthoptist is. Many people in the community or even other allied health professionals are not aware of orthoptists or what we actually do. So I'd like to take this opportunity to briefly explain my discipline. Orthoptists are university trained allied health professionals. We are eye health care providers specialising in assessment, diagnosis, and non-surgical management of eye and vision conditions. We also play a role in providing habilitation and rehabilitation to people with ocular and neurological vision impairment. On this slide, we have an image of a man holding a portable device and showing something to a little girl wearing glasses, holding her little teddy bear. There is a script on the image that says, helping to improve quality of life for adults and children with vision problems. Orthoptists are trained in understanding the complexities of various systems involved in vision. We are knowledgeable in a number of eye and vision conditions, including front and back eye pathology, eye muscle and binocular vision anomalies, and vestibular ocular dysfunction. Some orthoptists have also an understanding of how the visual system is affected by neurological conditions such as CVI, stroke, concussion, autism, ADHD, and neurodegenerative conditions such as dementia. Our extensive knowledge of various conditions helps us better understand the impact of vision on everyday function and support people with complex vision conditions such as CVI. To better understand CVI, I thought I would lay some foundations regarding how typical vision works. On this slide, we have a black and white image of Rubens vase. I like to use Rubens vase because I feel it provides an experience to explain and better understand the hierarchical nature of vision. Vision is made up of two significant sensory pathways. The primary visual pathway originates in the eye, and it's the start of vision. It gives us characteristic information about what we see, such as detail, shape, and colour. The next level of vision is the sensory visual pathway, which is brain processing, and this gives us meaning to what we see. When you first look at this image, our primary visual pathway is providing information about form, detail, colour, contrast, and this is what we see first. Then our secondary visual pathway takes over and our brain starts to think, is this the right way up? This is our spatial orientation working. Then we wonder, what is it? Some of you may see a vase first, and given the name, it's probably the most obvious and easiest answer. But then you might feel your brain working and your attention shifting to the image from the black area to the white area and say, no, I see two people facing each other. And now your mind's eye is bouncing between the vase and the two faces. On this slide, we have three overlapping circles creating a Venn diagram. The circles are titled primary visual pathway, secondary visual pathway, and oculomotor systems. So to follow on from Rubens vase, which provides an introduction of vision, I would like to provide a little more information. There are three primary components to help us see. You've already been introduced to the primary and secondary visual pathways, but the other aspect of vision is the oculomotor systems. These systems direct our eyes to help them work systematically and in unison. These three components to vision need to work harmoniously for us to be able to see, understand, and direct our vision to engage and interact in our environment. The image on this slide is of the primary visual pathway and shows how images move from the eye to the back of the brain. The first part of vision is light. light enters the eye and is converted into electrical impulses so it can transport information quickly from the eyes to the back of the brain, which is the occipital lobe. The primary visual pathway carries information about the characteristics and quality of vision, how clear or blurry it is, the extent of what you see and where objects are in the visual field, the colour and contrast of every object, and spatial and depth perception of objects in relation to each other and to self. Part of the primary visual pathway also controls our pupil reaction and manages our ability to see in different lighting conditions. On the right side of this slide, there is an image of the brain with a green arrow moving from the back part of the brain to the top, titled dorsal stream, and a purple arrow moving from the back part of the brain to the bottom, titled ventral stream. Many of us learning about CVI will come across either the image on the screen or a similar version of this. In CVI literature, most authors refer to the secondary visual pathway or the processing pathways as being made up of two streams. One is the dorsal stream, the where stream, which leads from the occipital lobe, which is the back part of the brain, into the parietal lobe, which is on top of your head. The other stream is the ventral stream, or the what stream, which leads from the occipital lobe to the temporal lobe, which sits on the side of your head, just above your ears. The dorsal stream allows us to process the whole visual scene. It gives us information about orientation and where objects are in relation to each other and to self. The parietal lobe uses information to provide visual guidance of movement, visual search, and enables us to shift our attention to different elements in the visual scene. The dorsal stream is also closely interconnected with the somatosensory, the motor, the frontal, and the temporal cortical areas to allow us to move, choose, and identify objects within the visual environment. The ventral stream predominantly looks after our ability to understand visual characteristics. For example, take the image of the brain noted on this slide. The shape of the brain is quite unique and it gives us a clue as to what we're already looking at. The different colours draw our attention and categorises parts of the brain. And finally, we use our acuity to read the labels. The ventral stream has strong connections to other parts of the temporal lobe and the limbic system. These areas integrate what we see with language and long-term memories and our emotions. The ventral stream also has connections with the frontal lobe and the parietal lobes. Through these complex interconnections, we give meaning to what we are looking at, and we're able to connect our emotions to what we see. In turn, creating an experience and a memory from which we'll lay the platform for learning. While the dorsal and the ventral stream are important in understanding the foundations of visual processing, this is a very simplified pathway. In reality, the pathways involved in processing visual information looks a little bit like this. So the image description, the previous slide's image of the brain is on the left side of the slide, and there is an arrow in the middle pointing to the image on the right, which shows multiple complex pathways moving to different labelled boxes that represent areas in the brain. As you can see, the connections to various parts of the brain are significant. So any insult to the brain can dramatically increase the risk of visual dysfunction and cause CVI. The image description. On the left of the slide is an image of the brain showing one of the many oculomotor systems. Whilst the sensory aspect of vision is quite complex, the whole visual system is underpinned by our oculomotor systems. These systems help us use vision efficiently and effectively. They enable our eyes to be aligned, which then facilitates the ability for both our eyes to work together at near and at distance. The oculomotor systems stabilise our vision when we're in different postural positions, such as walking, lying down, or riding a bike. They allow us to track moving targets while not causing us to feel dizzy or imbalanced. And as you can see, the oculomotor systems are integral to visual ability. Thank you for your patience while I explain the foundations of vision. I will now talk about CVI, and I hope the previous slides will help you better understand and contextualize how different, variable, and complex vision can be in individual with CVI. As we conduct more research and better understand this condition, the definition of CVI is constantly evolving. I've extracted two definitions from the literature that complement each other to help define CVI. CVI is a higher order visual processing deficit associated with damage to the visual processing pathway and higher order associative processing cortical areas. CVI is characterized by a verifiable visual dysfunction which cannot be attributed to disorders of the anterior pathways or any potential co-occurring ocular impairment. So in simple terms, CVI is a vision impairment caused more by the brain not being able to process the information we see, rather than the eyes not being able to produce a visual image. Inconsistencies in terminology causes great confusion and can also be a barrier to obtaining clear and accurate information about CVI. Commonly, the literature and in social media, you will see both the terms cortical and cerebral vision impairment being used. These two terms are frequently used interchangeably. However, traditionally, the term cortical vision impairment often referred to vision impairment relating to insult to the occipital lobe, which is the part of the primary visual pathway. And the term cerebral vision impairment was referred to brain insult in various parts of the brain, not confined to the occipital lobe. There is discussion amongst the experts about renaming CVI to avoid terminology confusion. So we just need to wait and see what happens in this space. So the diagnosis of CVI is a complex process. There is also no clear answer in the literature as to how to diagnose CVI. Research papers are reporting that CVI is being diagnosed more by the process of elimination rather than having a guideline for diagnosis. But based on the definition and my experience, I'm seeing either ophthalmologists or neurologists diagnosing CVI when there is a clear medical history of brain insult seen on an MRI scan, where there's evidence of cerebral insult to the visual areas of the brain, and individuals present with poor visual responses that are not age appropriate. Many ophthalmologists will also comment that the reduced visual response cannot be attributed to ocular pathology. But because there are no clear guidelines to diagnosing CVI, and this is an international concern, or it is done through a process of elimination, CVI can be misdiagnosed. The main condition it can be confused with are delayed visual maturation and autism. CVI can also mimic a significant refractive error in infancy. Delayed visual maturation is when a child displays reduced visual ability expected for their age, but by about 12 to 18 months, the infant's vision spontaneously improves and they continue to meet typical developmental milestones. Autism is another condition that may be confused with CVI. Both conditions have similarities, such as reduced attention, atypical fixation patterns, and avoidance to faces. However, autism can have very distinctive and different presentation to a child with CVI. Autism is characterized by a cluster of atypical patterns of behavior and awkward interactions. It's also commonly accompanied with difficulties with language, communication, sensitivity to sensory information. A child with autism has greater tendency to skim or show restricted and repetitive behaviour patterns. But this said, both autism and CVI can coexist. A high uncorrected refractive error in infancy can mimic a child with CVI. The infant will present with reduced visual behaviour, but when they are refracted and prescribed glasses, their ability to improve, their visual ability improves and they can follow a typical visual development path. CVI is relatively new to the ophthalmic profession. As previously discussed, CVI has no clear guidelines. While it is considered the most common cause of vision impairment in the developed world, in Australia, it's the second most common cause of vision impairment, with retinal dystrophy preceding it. CVI is leading the charge as the most common non-ocular cause of vision impairment due to advances in prenatal care, which has increased infant survival rates, advances in understanding brain function, and improved diagnostic methods. Worldwide, CVI has also been labelled as the emerging significant health concern. There are a number of causes of CVI, and this is no surprise given the complexity of the visual system. We saw in the previous slides that the scope of the neural networks involved in visual processing is quite extensive in the brain. So a slight insult can interrupt this delicate balance and cause CVI in some form. The most prevalent cause of CVI appears to be hypoxic ischemic encephalopathy, abbreviated to HIE. This condition results when there is not enough oxygen or blood to the brain. Another more prevalent cause of CVI is periventricular leukomalcia, or more commonly referred to as PVL. This is a condition where there's reduced white matter and nerve connections carrying information from one part of the brain to the other is reduced. Another condition causing CVI includes genetic and metabolic conditions. These conditions can result in either malformation of brain structures or how brain metabolizes information. Both of these conditions can affect how the brain functions. Focal and general insult to the brain from disease, infection, and injury can also cause CVI. So the image on this slide is a circle segmented into different colours that represent associated neurological conditions. There are numerous neurological conditions associated with CVI. The most common comorbidity includes cerebral palsy, which could involve hypertonia, which is low muscle tone, or hemiparesis, which is weakness to one side of the body. Other common conditions include epilepsy, hearing loss, and microcephaly, which is a significantly smaller head due to atypical brain development. The list here only reflects a small portion of associated conditions. An emerging comorbidity is central auditory processing disorder. Similar to CVI, this condition is not well understood and it is difficult to test and diagnose. CAPD is a condition where children have difficulty understanding what they hear. This is because there is a lack of coordination between the ears and the auditory processing areas in the brain. CAPD can exacerbate the presentation of CVI because hearing and vision have some similar functions, such as direction and location. So it's important, so this is an important factor to consider when assessing and also providing intervention to those with CVI. So the image on this slide is a circle segmented into different colours that represent associated ophthalmic conditions. CVI can also coexist with other ocular conditions. Research has shown that about 50% of children with CVI have associated eye conditions such as uncorrected refractive error, accommodative insufficiency, optic atrophy, coloboma, retinopathy of prematurity, and optic nerve hyperplasia. These conditions will impact information gathered by the primary visual pathway and will affect the quality and the extent of vision. Other associated conditions relate to ocular motor anomalies, which includes strabismus, which is a turned eye, oculomotor apraxia, the eyes can get stuck, and nystagmus, which is involuntary oscillations of the eyes. These conditions will impact how the eyes are able to accurately direct vision to be able to obtain information about their environment. The image on the left is of Australia with the flag superimposed on it. I've been fortunate enough to be involved in the first Australian study to look at CVI in Australian children. The data was extracted from the Australian Childhood Vision Impairment Registry, and this was a project that was sponsored by NextSense. Based on the data, we found that parents first suspected their child of having CVI before 12 months of age, and most of these children were actually diagnosed before their first birthday, which was really welcoming to see those results. The gestational age and birth weight are not necessarily contributing risk factors. However, these are some risk factors in other countries. Many children with CVI have 2 or more ocular conditions, such as nystagmus, optic atrophy, and refractive amblyopia. Many children with CVI had 1 or more coexisting comorbidities, including cerebral palsy and epilepsy, and the level of delayed development was strongly linked to the level of vision loss, which meant that severe delayed development was linked to greater severity of vision loss. This study formed the first snapshot of CVI in Australia, and it will hopefully be the foundations of much more research to come. The image description. The image on this slide is a puzzle with a central red piece. So in summary, CVI is a condition that results in reduced ability to use vision to understand and interact with the world. An individual with CVI will have some degree of insult to the brain, resulting in visual processing dysfunction. In combination with this, they are likely to have 1 or more eye conditions affecting the quality and the extent of vision, and their ability to coordinate their eyes to see may also be impaired. Therefore, an individual with CVI is likely to have all 3 vital components of vision affected. Additionally, an individual with CVI is also likely to have comorbidities such as cerebral palsy or global developmental delay that significantly impacts their motor function, speech and language, feeding, sleeping, emotional behaviours, and cognitive ability. The complexity of this condition makes it essential for the CVI care team to be multidisciplinary, including specialists, therapists, support workers, and educators. Quite often, the CVI team includes speech pathologists, occupational therapists, and physiotherapists to address urgent global developmental needs, which commonly overshadow the visual dysfunction experienced by someone with CVI. So why also include an orthoptist to the team? Because our knowledge and our skills place us in a distinct position to support individuals with CVI. We can enrich therapy programs by providing families and therapists with important information to help better understand the individual's unique visual profile and how their visual ability may hinder performance and progress of habilitation activities implemented by other disciplines. Orthoptists can also implement orthoptic-specific vision intervention to help improve impaired visual functions and work collaboratively with other therapists to integrate vision with motor development, social interaction, communication, language, and concept development. Many orthoptists working with individuals with CVI will conduct a comprehensive functional vision assessment. The primary aim of the functional vision assessment is to create a baseline of vision. Subsequent assessments are also important as they formulate a progress map of visual ability. I will talk more about functional vision assessments in the coming slides. Some orthoptists will also extend their practice to provide orthoptic intervention to facilitate an understanding of the visual world by supporting visual development and building visual capacity. Additionally, we can also provide specialist advice, support and/or education about the individual's ability to families, therapists, support teams and educators. Many families will seek a functional vision assessment for their loved one. However, the process of obtaining specific information about vision can be confusing for families because various disciplines, including non-eye health professionals, also offer functional vision assessments. But it should be noted that information gathered by orthoptists will be different to that obtained from non-eye health professionals. This is purely because we have a different skill set and approach in assessing vision. An orthoptic CVI functional assessment is heavily focused on vision and visual ability. Orthoptists will use a significant amount of clinical thinking to ascertain information about the integrity of various visual systems. Because we understand the intricacies of vision and how it works with other functions such as movement, coordination, communication, and cognition, we're able to provide insight into how vision is being utilised and how it can be employed to optimise development and learning. An orthoptic functional vision assessment will commonly be comprised of an assessment of visual function, which assesses the integrity of the primary visual pathway, visual processing anomalies, which assesses the secondary visual pathway, an oculomotor assessment, and also we look at observations. So we're looking to see how synchronous the systems are, what the limitations are, and how the individual is using vision to interact with their environment. All of this gives us information about functional visual ability. When assessing CVI, you're not only looking at how well they can see, but also how they can use their vision to access their environment and social interactions. The outcome of the assessment should be analysed through the lens of CVI characteristics observed, visual function results, visual processing outcomes, and visual behaviour characteristics. And I'll go through all of this in more detail now. So as part of the functional vision assessment, the orthoptist should cross-reference the outcomes against the typical CVI characteristics. So this list was created through early research conducted by Dutton and Jacobson. The list highlights common signs seen in a child with CVI. They may present with one or more of these characteristics. There are a number of functional vision assessment tools used by non-eye health professionals that use these characteristics as the foundations for an observational assessment. Whilst these assessment tools are important to gather information about functional vision, it is important to also consider that these characteristics should be closely assessed with an eye healthcare professional assessment. We're able to evaluate the underlying factor as to why these characteristics exist. For example, a visual field preference may be because they have visual field loss, or because they have poor head control, or they're not able to coordinate their eyes, or there's limitation in eye movements. So also to be mindful is colour preference. So many people report red as a preferred colour that is appreciated. So this should be closely evaluated, as there are many eye conditions and brain pathologies that can impair our ability to see red and also shades of red. The visual function portion of the assessment will use clinical tools and modified tests. This slide does not contain the full list of elements tested, but it does highlight the main characteristics that can be present in CVI. One misconception of CVI is that an individual has to have reduced detail vision. There is mounting research, including the Australian study I was part of, that indicated children with CVI can have normal to near normal vision. Therefore, based on contemporary research, reduced visual acuity is no longer considered an indicator for CVI. Contrast is our ability to see how visible an image is before it fades into the background. This is an aspect of vision that can commonly be affected. Reduced contrast can have implications in being able to see and recognize faces, being able to play with certain toys, and being able to see pictures and diagrams. Visual field is how much you can see to the sides and represents the extent of vision seen. This can be true loss of visual field if structures along the pathway have been insulted. But visual clutter and attention can impact the functional ability to access the field of view. So there's a number of individuals that are quite happy to share their experiences and provides us with a lot of personal insight. So CVI individuals report having a dynamic field of view where the field of view is larger when there's less images in that scene, and more constricted when there are multiple images in a scene. Colour vision is usually left intact and unaffected, but the oculomotor system is commonly impacted, and this is because it comprises a number of different pathways. One common impact is misalignment of the eyes, and this will affect binocular vision. Fixation is how stable the eyes are when they're looking. There are various complex factors that can cause fixation instability. It is common to see an individual with CVI have very brief fixation duration periods and also present with refixation behaviour where they look away, and then they return to look. The image on this slide is of a child looking away while reaching for an orange block. The visual processing characteristics are heavily based on the dorsal and ventral stream dysfunction. The dorsal stream, which predominantly resides in the parietal lobe, is embedded in processing orientation and spatial information, visual guided movement, and also visual attentional control. Insult to the parietal lobe can result in loss of a portion of the inferior visual field. Additionally, a person with dorsal stream dysfunction can present with an array of visual spatial perception, coordination, and attentional difficulties. This can include akinestosia or dyskinestosia, which is a total or partial motion blindness, or the difficulty to perceive moving objects. This is something that we need to consider as movement is often employed to gain visual attention. Hemispatial neglect and extinction is characterized by reduced awareness of objects, either to the right or to the left of a person. Simultaneous agnosia is the difficulty to perceive a certain number of objects at the same time. The impact of simultaneous agnosia is compounded by visual crowding. Optic ataxia is the inability to accurately reach or point to an object under visual guidance, even when directed by sound or touch. And oculomotor apraxia is an oculomotor disorder where the eyes have difficulty initiating voluntary movement and they get stuck in a gaze. The image on this slide is the same as the previous slide. So the ventral stream resides in the temporal lobe and is primarily responsible for cognition, for the cognitive architect underpinning object recognition and form representation. The ventral stream receives information about the physical characteristics of objects, such as colour, form, and contrast. It has close relationships with speech and language cortices to give meaning to what we see. This pathway also interconnects with functions relating to attention, working memory, and object salience. So the ventral stream not only provides a description of what we see, but it's integral in judging the significance of the object that we're looking at when compared to other objects. Insult to the temporal lobe can result in loss of a portion of the upper visual field. Additionally, damage to the ventral stream can cause varying degrees of visual agnosia, which is an overarching term to describe a disorder of visual recognition. In visual agnosia, objects, faces, and colours can be disrupted separately or in combination. So appreciative and associated visual agnosia refer to the inability to accurately appreciate a shape or attribute a meaning to an object. This type of dysfunction might translate when an individual has difficulty recognizing and connecting a real life, animated, or silhouette image of the same object. Prosopagnosia is difficulty being able to recognize faces, even of those of family and friends. Color agnosia affects color recognition, color name association, and color object association. Different to color agnosia is cerebral achromatopsia, which is a form of color blindness. But the underlying cause of desaturation of color perception is due to insult to the temporal occipital lobe and not necessarily to the eyes. Ventral stream dysfunction is also associated with optic aphasia, which is the object cannot be named purely with visual input, but the object can be named and recognized through touch and sound. So the image on this slide shows 3 scans of the brain with the coloured area showing brain connections related to vision. The image on the left is of a typically sighted person. In the middle shows someone with ocular impairment, and the brain connections are fairly similar here. And then on the right is an image that shows significantly reduced connections in someone with periventricular leukomalacia or PVL. Individuals with CVI can present with distinct behavioural characteristics, which can present as lack of or delayed response, reactive response, and adaptive response. It should be considered that these behavioural responses may be due to individuals with CVI not having sufficient brain connections to cope with the input of visual information. So lack of or delay in visual response. One very common characteristic is visual latency, which is the delay to initiate a visual response. As we know, visual connections and interconnections in the brain is quite extensive. It takes longer for information to travel from one part of the body to the brain, and then within the brain, and then back out to the body. It is vital that we go slow and provide time for those with CVI. Time gives them a better chance for information to be received and then processed and then sent out to produce a function. I also very commonly see children and adults requiring visual or brain breaks where they are absent for a short period of time. This break allows vision and the brain to rest momentarily before having to work really hard again. Individuals with CVI can present with reactive responses to their visual environment. We can see outbursts where they are overwhelmed by the experience, and we commonly refer this as a CVI, outburst. They also may withdraw as well. We also need to be continuously mindful that CVI is a processing dysfunction. So if the individual cannot understand or what they see, or they're uncertain about the situation that they're in, this may increase their anxiety. Adaptive responses can also be observed in the form of light gazing, where the light is an easy visual stimulus for them. Some may also reach for your hand or be close, especially when you're out in busy environments and they're having to move through these crowded environments. Your closeness enables them to feel safe and not have to solely rely on vision. Other behaviours that may also be observed are looking away during a conversation or when reaching for an object. Again, this adaptive response allows them to continue to participate in the activity without vision because the simultaneous use of vision is just too difficult. Individuals with CVI might experience fluctuations in general and visual performance within the day and from one day to another. This is because their visual ability is influenced by various endogenous and exogenous factors. Exogenous factors include influential elements outside of the body and in the environment, such as lighting and glare, the amount of level of noise in their environment, visual crowding, and positioning of objects in their surroundings. Endogenous or within the body factors may at times be more influential in their level of alertness and therefore ability to see. These include eye, head, and postural control, general health, internal body temperature regulation, thirst, hunger, fatigue levels, and level of anxiety as well. Additionally, I've seen medication also affect vision. Amendments to dosage can cause lethargy and reduced tone, which can then impact function and vision. As we've learnt, our ability to use vision is multifaceted and complex. So how do we improve visual understanding in a child or individual with CVI? One way is through orthoptic intervention. Orthoptic intervention is highly individualised. I have a number of children and adults that I see, and none of them are on the same intervention plan. I use a strengths-based approach to intervention, which is aimed at facilitating visual development and integration of vision into general function. How I do this is by understanding how they prefer to use their vision within the parameters of their visual limitations and create different situations and environments where they can use their vision and simultaneously experience joy. When we're happy and successful, then this builds confidence and a memorable experience, which then forms the foundations for learning and exploring. It also sets them up to be open to being challenged, to then be able to be pushed outside of their parameters. Orthoptic intervention uses a play-based approach. However, assistive technology in the form of switches and magnification can also be employed to create a visually accessible task. Another important point to make here is that an orthoptic intervention is not necessarily to develop vision so it can be used as the primary sense. Because of the neural complexity, a person with CVI may have vision, but their ability to consistently access and maintain visual engagement can actually be quite exhausting. So it's important to understand what the individual's sensory preference is, and then we can use vision as a supporting sense to add information and understanding. So in conclusion, I'd like to leave you with some points to consider. CVI is unique to every individual. There are no two people who present with CVI in the same way. Individuals with CVI can have normal or near normal vision. And this is quality of vision, specifically detail vision. If there is uncertainty about how much an individual with CVI can see, then just request an orthoptic functional vision assessment. CVI support should be multidisciplinary, including an orthoptist, with the individual and the family at the centre of care. Vision does not always need to be the primary sense, but it can be a complementary and supporting sense. So some resources that I'd like to leave you with. So the one that I rely quite heavily on is CVI Scotland. This is an amazing resource. It has a different range of resources on offer. It's got personal insight. It's got evidence-based practice. I highly rate this website. The other websites on the screen are US-based, so the National Eye Institute, the American Printing House for the Blind, Pediatric Cortical Vision Impairment Society, Perkins CVI Hub, and Little Bear Seas. So connecting with others is really important when we're talking about CVI. So my colleagues and I found that there were a lot of communities in the US that provided support, but there wasn't anything in Australia. So together we founded the CVI Community Australia, and this is specifically Australia based. So it's a place for families and professionals to come and share experiences and also resources. If you are interested, we do have a Facebook page, which is active. Please contribute as well, ask questions, and we'd love to hear your experiences through that Facebook page. It's also important to have access to advocacy groups. So Blind Citizens Australia is a great resource. I know that a couple of my clients have utilised them when they've had NDIS challenges. And then the Paediatric Vision Impairment Alliance, we're an advocacy group of leaders in paediatric vision impairment that provides a voice to Australian children with the vision impairment and their families. So thank you very much for your time tonight and for listening, and I look forward to your questions.